Great. Thank you, Dana, for the introduction. I mean, this is the second year I'm doing this. And just a brief introduction. My name is Qing Yan. Dana, you did great pronouncing my first name, pronounced as Chin. I serve as the interim chief of endocrinology at UCI, also medical director of our UCI Diabetes Center. So today, so I'm going through a little bit diabetic basics, dietary management as a key, and also how the blood sugars are regulated with the goal for you to understand how to manage diabetes based on this basic knowledge. So just quickly go over the diabetes diagnostic criteria. I think if you have any family member or somebody yourself diabetic, then these numbers you should be familiar with. Most commonly used is fasting sugars above 126, or the A1C, which reflects the average sugars in 3 months, 6.5. These are two commonly used criteria for diabetes diagnosis. Now, if your random sugar is above 200, or we do what is called OGTT, I will have another slide for this, give you 75 grams of sugars. And if 2 hours your sugar is above 200, either of these would make the diagnosis of diabetes. Or if the sugars are kind of mildly elevated, not to the extent to very high, meaning if your fasting sugar is between 100 to 125, or A1C between 5.7 to 6.4%, you meet the criteria of pre-diabetes. So I give you these numbers, one FYI. Second is to let you know these numbers are not really randomly picked. So these are from the scientific studies by the American Diabetes Association back in 1997. That has to do with diabetic complications. Specifically, today's topic is retinopathy, the diabetes-related eye conditions. So what happens is, after there are 3 lines here, one dot line is covered, reflecting fasting sugars 2 hours after you eat, for the postprandial, or A1C, which, as I said, reflects the average sugars in 3 months. So y-axis represents the retinopathy, and these are the fasting sugars, or A1C. As you can see, when the fasting sugars are lower than 100, you don't see much of the signal of retinopathy, similar to A1C. If it's below 5.6, you don't see much of signal of retinopathy. But if your A1C above 5.6 or above 99, you start to see the signal, meaning increased incidence of retinopathy. And the curve is the line is quite straight, going up quite significantly after the sugars are above 100. Now, in a scientific way, there is a way to calculate what would be the cutoff. So in the end, by calculation, this is 50% of this curve. So American Diabetes Association set the criteria for fasting sugar of 126 and A1C of 6.5. Again, these numbers are not random numbers. They have scientific evidence, mainly for the eye complications. Therefore, for diabetic patients, for the optimal diabetes management, to prevent the retinopathy, you want A1C to be 6.5% or fasting sugars are below 126. The problem is, nearly half of the diabetic patients' liver can reach this goal, even 7%. It's just hard for them to do. I think for this community lecture, I would give you some basic information about how human body controls blood sugar. I think understanding this would be helpful for diabetes management. So normally, the blood sugar is balanced. This is a molecule for glucose. We refer to sugar. It's a very small molecule with 6 carbons. Is into chemistry not important, but it's just a small molecule. At when it goes too high, it really has a lot of damage to your body. But usually in the blood, the sugars are maintained in a very narrow window because the body has a very sophisticated system to balance the in and out. Of course, one in is really controlled by food, and also another in meaning into the circulation, into the blood, causing high or low sugars. Could be from food or could be produced by your body. For the sugar out of your blood, your circulation, that could be used or could be stored. If these two are balanced out, then you achieve normal sugars. If you have increased in or reduced out, then the sugars would be accumulate in your blood, causing diabetes. This is basically the basic way for the sugars to be high. Now, the food is a main source of sugars after you eat. You can imagine that, right? It's mainly from digestion of carbohydrates. Carbohydrates just replace the name of different sugars, basically, sugar molecules. And after you eat the carbohydrates, they are digested in your digestive system and absorbed into your circulation and become glucose. So carbohydrates, we have what is called simple carbs. You can see it includes the glucose, fructose, and the galactose. So you can see they are all very small molecules. These simple carbs or sugars are very easily absorbed from the gut. So it can rapidly increase your sugar. And there are also called complex carbs. So those carbs are kind of a accumulation of simple carbs. A lot of simple carbs kind of linked together, causing complex carbs. Those carbs need to be digested by the intestine, become small simple carbs to get absorbed. And also mainly exist in the starch or bread, those kind of things. They're also kind of get name of carbs, but they are not really digested. Those are called fibers. So carbohydrates include simple carbs, complex carbs, and fibers. The reason we need to know this has to do with the impact on the sugars. For the simple carbohydrates, as I mentioned, the fructose or glucose, mainly in the sweets, whatever we are eating, syrup, honey, those are very sweet stuff. And fruits mainly is composed of fructose, and sweet other, chocolates or ice cream type of things, and in the milk. So these are foods contain a lot of simple carbs. If you are diabetic and if you eat these kind of things, it can very rapidly increase your sugars. So complex carbs, carbohydrates, those are digested a little bit slower, as I mentioned. They need to be cut to become smaller sugars get absorbed. It takes some time. So those are grains, starchy vegetables. They are high in carbs. but relatively called complex carbs, relatively slower in absorption. And these food, whole grains, nuts, legumes, they are carbs. They also have some real carbohydrates, but a lot of fibers, as I mentioned, fibers are not really digestible. So they will be mixed together with carbs, slowing down your absorption. They will cause not dramatic high sugars if you eat them. So understanding these different carbs will be helpful for you to understand which one would cause rapid high sugars. That has to do with a medical term called a glycemic index, called GI. That is a value to measure how much specific foods increase blood glucose or sugar levels. So if it's below 55, it's considered low GI. If it's below 70, considered medium. And if it's higher than 70, it's considered high GI. So you can see this is just a simple graph showing, low glycemic index food does not raise sugars that much, but a high index food increases sugars quite dramatically. So these are just examples of the high versus low GI food. Some can be surprising. For example, oatmeal. A lot of people think it is healthy. It is considered healthy, but you can see its GI is as high as 87. Bagel, the GI is 103. White bread is 100. So these food can really increase your sugars quite dramatically. And the vegetables, they have carbohydrates inside, but they have much lower GI. And of course, they have fibers inside. The absorption is slower, so they are favorable and better for diabetes management. And the fruits are considered healthy, but as I mentioned, there are a lot of simple sugars, specifically fructose inside, that can cause quite high rapid increase of sugars and can be quite dramatic, especially those food like pineapple, very sweet, and watermelon, very sweet, can be absorbed very fast and causing high sugars. Even some proteins, like those beans, considered a healthy diet relatively, but they can raise the sugars quite significantly. So understanding the GI would be important for you to choose the right food for you. Of course, GI is just one kind of thing you need to understand. It has limitations, as you cannot really only rely on GI for your dietary management. You still have to consider the quantity, how much you eat. Even for those food with lower GI, if you eat a lot, it will cause problem. They're also affected by other factors, such as whether you are eating these carbohydrates alone or you are eating with other food together, that would affect the sugar levels. To make things more complicated, everybody can be different, even though you consume the same amount of sugar. So this is an example called OGTT, oral glucose tolerance test, in which we give the patients 75 grams of glucose. This is simple sugar. Then we measure glucose levels every 30 minutes. But most people can see the sugars go up, glucose levels go up between 60 to 90 minutes. But you can see the patterns can be quite different. So some people, most people are called biphasic. So this green line, the sugars go up, peaks at 90 minutes, then goes down. A lot of people have this pattern, but some people have continuous rise. They don't peak at 90. They peak 2 hours or even later on. And some people flat a little bit, then go up. So you can see the diabetes management can be quite challenging because it has to be highly individualized, depending on who you are, how you absorb the sugars. You can think about that. The food can affect your sugars, and the way you absorb or consume the sugars in the blood can also affect your sugar levels. But overall, the rule is relatively low carbs. Recommendation is 40 to 60 carbs per meal. Keep the good GI glycemic intakes in mind. Reduce portion is important, and what to eat and how much to eat is highly individualized. And of course, balance the diet will be important. So that's the first thing for the sugar that increase the sugar levels. And then in addition to the food sugars, and the human bodies also produce sugars. So this really came from the evolution. During the evolution, you can see the brain volume increased, almost doubled over the several million years. When the brain size doubled and intellectual capacity increased, and then the interesting thing is brain really cannot use other nutrients, especially fat, is a major energy source usually. But brain really relies on the sugars as an energy source. In ancient humans, most of the days they didn't have enough food. They had to, go look for food. So they were hungry most of the times. So to maintain the brain function, the body, specifically the liver, would produce sugars for them to maintain the sugar levels and for the normal brain function. At that time, it was very important. But right now, of course, for diabetic patients, when you have high sugars, but your liver continues to make sugars for you, that would further raise your glucose levels in the circulation. And especially the factors that raise your sugars are very common right now. Many stress hormones. These are cortisol, epinephrine, glucagon. These are all clinical stress hormones. When you are stressed, these hormones are released and they act on the liver and push these called substrates kind of materials for the glucose synthesis. And then glucose will go to the blood circulation, causing high sugars. So in addition to food, liver glucose production is a major source of high sugars in the circulation. This is reflected in these kind of, this we call a CGM, continuous glucose monitoring. We monitor the sugar levels 24 hours a day. You can see some patients, they always have high sugars in the morning. At night, it was fine, going to bed without eating anything overnight, the sugars go up to 200s. You can see, a lot of patients were asking why, because they weren't eating anything, why the sugars go up. It's because the liver was making the sugars for them. Again, as I mentioned, the stress, if you don't have a good sleep or something, stress you out, would contribute to this increase. And these are most likely caused by the food the patient was eating. So for the sugar production from liver, very important to reduce stress, have a good night's sleep, treat sleep apnea. A lot of obese patients have sleep apnea, causing a stress at night that will increase the liver glucose production. And for some people, you try to avoid coffee in the afternoon. And another way is to add a medication called metformin, which specifically lowers the hepatic liver glucose production. The third, so these are two factors for sugars in. There are two factors for sugars out, to remove the sugars out of the circulation. One is used. The most significant organ for the for the sugar consumption is muscle. Muscle has a molecule called glucose transporter number 4. So the muscle cells cannot really use the sugars, glucose specifically, without GLUT4. GLUT4 translocate, basically deliver the sugar from blood into the muscle cells. Therefore, GLUT4 translocation is critically important for the muscle to use the sugars. And insulin is a major hormone that promotes the GLUT4 translocation to the cell membrane to move the sugars into the cells for the consumption. The second major one is exercise. Exercise is an insulin-independent mechanism. It does not require insulin. Muscle contraction can push the GLUT4 to the cell membrane and to take in glucose. And again, here, stress hormone is a bad thing because stress hormone would inhibit the GLUT4 translocation, so the muscle cannot get sugar and your sugars would be higher. This is just an example or the experiment. So it's from the mouse studies. So what the scientists did was to take out the muscle from the normal mice or from the obese mice, and they contracted the muscle using the artificial system. And you can see, similar to insulin, insulin is a strong stimulator for glucose use, sugar use. And the contraction of the muscle had a similar effects. And in obese patients, because of insulin, called insulin resistance, insulin doesn't work very well. Even for exercise, the glucose use is much, much lower than the normal mice. And this is human data. You can see exercise can lower the sugars in most of the patients. And usually the moderate exercising can lower sugars more. Actually, if you do the very high intensity exercise, some people may have high sugars, but overall you would have low sugars over time. So that's a sugar use. We talked about the muscle, and insulin is a major hormone to move the sugars into the muscle for use. And exercise is an insulin-independent mechanism, and stress hormone is very bad for not only for the liver to make sugars for you, also inhibits glucose use by the muscle. And the last one for the sugar out is storage. The storage is a large molecule called glycogen. So this actually is, you can see a lot of branches. So every small dot is one molecule of glucose. So glucose is accumulated to become a very large molecule called glycogen. So glycogen is stored in the liver and muscle, and when you need it, and as released. And the glucose can also be used to form the fat. And insulin is a major hormone to promote the glucose storage to become glycogen or become fat. So you can imagine if you don't have insulin, or insulin is not working, then you will not be able to store your sugars into these large molecules. Then you would have high sugars because of lack of insulin in type 1 diabetes, or insulin doesn't work in type 2 diabetes. So again, that's important in terms of lifestyle management of diabetes. You want to reduce the sugar in and increase the sugar out. Of course, insulin is a major way to control sugar out. But from lifestyle point of view, you want to reduce the carb intake, and you want to reduce glucose production by relieving the stress, and you want to increase the glucose out of the blood into your muscle by exercising, and you want to increase the storage by improving insulin action through weight loss. And in the end, you can maintain normal glucose levels in the blood. That's how much I have. Thank you very much for your attention.
Dr. Yang, would you like to answer? There's a question in the chat.
Sure. Do we answer the question altogether later, or do you want to ask right now?
Well, why don't you field this question now, and then maybe at the end there will be
Okay.
some for the group.
Okay. Should I answer right now? Sorry.
Yes, please.
Okay. The first question, may I ask a question? If eat nuts or other fibers at the same time when I eat fruits and sweets, can they prevent sugar spike after meals? Well, so you don't want to eat fruits and sweets alone. As I mentioned, if you eat them alone, in most cases, if you are diabetic, of course, your sugars will increase quite significantly. So in most cases, you want to mix them together, or usually what I recommend them is to eat after your meal. You eat something and then you walk. As I said, exercising is a way to consume sugars. So by the time the fruits or sweets are start to getting absorbed into your circulation, and your exercise activity, muscle contraction would simultaneously, the time will fit together for those sugars getting to muscle, get used. So with empty stomach, it's very bad to eat the fruits and the sweets with empty stomach. The second question is how to improve insulin sensitivity by losing weight or certain exercise. Both. If you lose weight, the magic number is 7% of your weight. If you lose your 7% of weight, you will dramatically improve your insulin sensitivity. And exercising is a great way to improve insulin sensitivity. As I mentioned, and not only increase the number for glucose transporter for that transporter, but also increase the capacity for the not only the number, but also increase the capacity to move to the membrane for the glucose to get into the cells. The third question is there any type of diet that is ideal for keeping blood sugars consistently at a good level or prevent type of diabetes in those most at risk? Yeah, that's a very good question. So there's a magic food. As I said, everybody's different. Overall, the balanced diet is important. So what happens is for the prevention point of view, so a lot of people during the period or phase of pre-diabetes, so what happened is their pancreatic islets, as a kind of cells, make insulin for you. Actually, the fact that you are pre-diabetic, you're not diabetic, it's because your pancreatic islets are working very, very hard to make a lot of insulin for you. Then a lot of insulin will help you to maintain the sugars in a kind of subabnormal range. But the problem is, if you stimulate the pancreatic islets for long, they will give up. So it is very important to avoid the sharp increase of sugars. Some people, if you measure the A1C, it can be, say, 6.3, which is in a pre-diabetes range. But if you were measuring the sugars over time, 24 hours a day, you see a lot of spikes, especially after they eat those simple carbs. So if you do that quite frequently, it actually stimulates or damages the pancreatic islets over time. In the end, you would go to diabetes. So there is a theory called glucotoxicity and called lipid toxicity, meaning high sugars are toxic to the insulin producing cells. So it's important to have good food for you. And I think if you are pre-diabetic, you want to prevent the diabetes, you probably should see a doctor to find an endocrinologist to see what is a better way for your diet, or dietitian, of course. Yeah, Mediterranean diet is great. So plant-based is great. Just one word for the plant-based diet. It's very good, very healthy. And what happens is we've seen a lot of vegetarian patients having diabetes. So there are really many plant-based, and the problem is they eat a lot of carbs, rice, noodles. And what happens is that those carbs, especially those very high carb content food, then they actually stimulate insulin a lot, in which case they accumulate fat in the stomach, causing central obesity. And then even those people can have diabetes. All right, I think I stop here. Let's go to Dr. Mehta's talk, and then we'll answer more questions later.
All right, that was a great talk. It's one of these things where fundamentally understanding what causes the sugar to rise is really important to be able to have a healthy life, even for people who aren't diabetic. And a point that Dr. Yang had at the end, I really want to emphasize, as a vegetarian, it's really easy to become a carbitarian, right? Eating lots of breads and simple sugars can spike your blood sugar just as bad as eating sweets can. And it's more likely to, and that's why we tend to see, especially in this population, diabetes pooling in the Hispanic and East Indian populations, because they tend to eat a lot of carbs in their diet, as I know from a childhood eating lots of carbs in my diet. Thankfully, I'm not diabetic, but I treat a lot of diabetes and a lot of diabetic retinopathy. So my name is Mitul Mehta. I'm a clinical associate professor of ophthalmology at the Gavin Herbert Eye Institute at UC Irvine. I'm also the fellowship director of vitreoretinal diseases and surgery, and I treat diabetes all day long. So vision loss and diabetes comes from a lot of different factors. The one thing that most people have heard about is cataracts. And most people think of cataracts as a disease of getting older, which is true, except in diabetes. If the blood sugar is high, it causes a specific type of cataract called a diabetic cataract. And this type of cataract tends to cause clouding of the lens, which causes a lot of glare, especially. People tend to notice it when they're driving at night and the headlights are coming at them. And it makes it almost blinding to see at night. But during the day, their vision might be pretty good. So it's one of those things where it tends to be more situational, and people just kind of stop doing a specific activity because it's just less comfortable for them. They may not be able to put their fingers on it, but it does affect people's lives. And it's one of the signs of diabetes. The other thing that diabetes causes, specifically in the eye, is ischemia. And ischemia is a lack of blood flow, because ultimately diabetes is a disease that affects blood vessels. And you need blood vessels for any living tissue to survive in the body. And if you have lack of blood flow to your nerves in your eyes, in your legs, in your hands, your feet, any part of your body, those things tend to die, and those nerves tend not to function as well. And so by damaging the blood vessel, diabetes causes ischemia, which leads to these other problems like neovascular glaucoma. Your body's trying to grow new blood vessels, but these new blood vessels block the drainage canals from the eye, and it raises the pressure of the eye very high. And that can cause irreversible blindness. So neovascular glaucoma is a very bad complication of diabetic retinopathy. And diabetic retinopathy itself causes vision loss in several different ways. And we'll go over these over the course of this talk. But diabetes macular edema, vitreous hemorrhages, and tractional retinal detachments are the three main causes of vision loss from diabetic retinopathy. So in diabetic retinopathy, this is the leading cause of blindness in working age people in the United States. Even in patients who do everything right, at least 5% would benefit from surgery. If you remember from Dr. Yang's, one of his first graphs, he showed people with A1Cs that were relatively low and percentages of diabetic retinopathy. It wasn't zero, even for people whose A1Cs were in the 5 range, some even in the lower ranges. And so sometimes people just have the inclination and the genetics to be more susceptible to diabetic changes in their eyes. So our goal for patients is to have a hemoglobin A1C of less than 7.0, control the blood pressure, and not to smoke, because all of these things together affect blood vessels. So it's not just your diabetes. Diabetics tend to also have high blood pressure. So controlling the blood pressure and other factors that affect the blood vessels in the body will also affect them in your eye. So the lining of the blood vessels in the eye become damaged by diabetes, and these blood vessels start to leak into the retina and cause it to swell. And the swelling makes it physically difficult to see. And this tends to happen more significantly in the very center of the vision, of course, because the center of your vision has the most metabolic need, and so it has a lot of need for oxygen. And this oxygen is affected by the amount of swelling that happens between the nerve cells in the center of the retina. We call it the fovea. The body also tries to grow new blood vessels because it doesn't have enough oxygen to these tissues. So it tries to grow these new blood vessels to get more oxygen to the nerve tissues in the retina. And these new blood vessels bleed and they form a scar, which damages the retina even more, and it causes blurry and distorted vision. So the symptoms that you could know if you can start having diabetic retinopathy and you want to know what's going on, and you want to know before it becomes advanced. This is not something that causes pain usually, not early on at least. Neovascular glaucoma can cause pain because the pressure of the eye can go very high, but that's a pretty late stage finding. Early on, you may not notice any changes in your vision. I had a bunch of patients today who were 20/20 with some pretty bad diabetic retinopathy. That was basically a time bomb, and so we had to treat that. And they were asking me, like, I can see fine. Why are you giving me an injection in my eye? And the reason is that if I don't, you will probably go blind pretty soon, and it may become irreversible. So these are the things we have to do, even patients who have good vision, to prevent problems later on. Over time, the vision can get blurry, distorted, or even dark. This can happen either gradually or suddenly. You can be blind in one or both eyes temporarily or permanently, depending on what the actual cause of it is. So there's two general types of diabetic retinopathy. There's non-proliferative diabetic retinopathy, or NPDR, and those proliferative diabetic retinopathy, or PDR. In this context, proliferative means growing new blood vessels. We call this neovascularization. And like I said before, the neovascularization causes problems because your body is not supposed to have new blood vessels in your eye. If you cut your arm and you get new blood vessels, that's fine because you don't need to see through the tissues in your arm. But in your eye, everything needs to be clear for you to be able to see through it. So having new blood vessels that are fragile and are more likely to bleed tends to cause a problem. So the treatments. Obviously, we want to control the blood sugar, blood pressure, cholesterol, and prevent smoking. I'm sure most people on this call have heard the term that smoking is bad for you. It is, so don't smoke, okay? One thing we do a lot of nowadays is eye injections of medications, meaning injections into the eye or around the eye. It sounds worse than it actually is. We do a really good job of numbing the eye to make it less uncomfortable. It's not completely without discomfort because we have to sterilize the eye with dilute betadine or povidone iodine, just like your mom used to use when you cut your hand and you got dirt in it to clean off all the infection, right? We have to make sure that the eye is sterile before we inject it so that we don't introduce infection into the eye. So that's the most uncomfortable part of the procedure. But for the most part, it's pretty numb and patients tend to not have much of a problem with it. We also use lasers in the eye, and sometimes we do surgery as well. So this is a normal eye in cross section. You can see that this eye has a contact lens on it, but this is like you're looking through the side of the eye. Let me see if I can get my cursor to show. There we go. Let's see here. There we go. So this is a contact lens on the eye. Over here is the iris. This is the lens that turns into a cataract. And everything here in the back is the retina. This little dip right here is the center of the retina, or the fovea. And this is the most important part of your vision. Everything outside of 1/2 millimeter from this little point right here is not good enough to see to read. You have to be within this area to have the level of visual acuity to be able to make out letters. Beyond that, we're talking about the big E on the chart. This is the optic nerve, which connects to the brain. So the eye is actually part of the brain. The retina is part of the brain. It's like an outpouching of the brain, and is directly connected to the brain. So retinal disease is a brain disease. And so when I look inside people's eyes, I'm looking at their brain. So this is what it looks like when I look inside the eye. You can see the optic nerve over here, and you can see the blood vessels here. This is a venule, and this lighter one here is an arteriole. These are the arteries in the eye. This is what happens when somebody has non-proliferative diabetic retinopathy. This is a pretty severe version of non-proliferative diabetic retinopathy. But in this specific case, this patient has several different problems. You can see the hemorrhage, you can see bleeding, these different areas here. You can see this little aneurysm here called a microaneurysm. These yellow spots are exudates, which is the protein that was in the blood that once the blood kind of gets absorbed, the protein gets left behind and it leaves these exudates. And these are all things that we look at when we look inside the eye to look for diabetic retinopathy. And we also do something called a fluorescein angiogram, where in the office, I'll inject some plant-based dye into a vein in your arm, and we'll take pictures of your eye every couple of seconds to look at how the blood flows in your eye. And this dye, which is a plant-based dye, will go through your blood vessels and it'll light up in these areas. And in this way, we can look at little aneurysms. These are called microaneurysms, and we can see them leaking, and we can see areas that are dark because there's no blood flow. We call it ischemia. And we can see this leakage here from these aneurysms. This is that diabetic macular edema, or the swelling in the retina that we were talking about. So we also do something called an OCT scan. This is a laser scan of the retina. It's a really bright flash of light, but what it does is it lets us look in cross-section at the center of the retina. So with this, in a live person, I can take an image and look in cross-section at microscopic details in the eye. For example, in this bottom one, this is a normal fovea or normal retina. In the center of the retina is the foveal depression. It has this little dip here where the arrow is. And you can see individual cells in the eyes. These are all individual cells in the eye you can see. And when we look at this, we can see live what is actually happening. And when someone has diabetic macular edema, they have the top picture here, where you see these black cysts. These are technically cystoid spaces. They're not actually cysts. That's a medical term, but there's bleeding inside the eye. You can see this brighter stuff here is actually bleeding because it's a reflection of the laser light back to the scanner. And this is how we look at diabetic macular edema. So when we do injections in the eye, we inject through the pars plana, which is this area of the sclera, or the white part of the eye. You can see the retina doesn't reach this area. So we can enter in and out of this area without causing damage to the retina. And then we inject the medicine into the vitreous cavity, which is this area here. And the medicine diffuses across the space into the eye and affects the retina, and it treats the retina. Sometimes we'll give injections underneath the eye here, down in the subtenon space. And so in the subtenon space, we can get the medication underneath the eye and behind the eye. And sometimes this allows us to give steroids or larger medications that we want to last for longer periods of time in the tissues around the eye, so it slowly diffuses itself across into the retinal space, into the eye. There's different types of medications we inject. There are several different categories in general, and one of them here is called anti-VEGF. So VEGF stands for vasoendothelial growth factor. This is the factor that causes your body to grow new blood vessels, and it also causes the blood vessels to leak. So when we have this VEGF being released in the eye, it causes the growth of new blood vessels, and it causes the leaking of blood vessels that causes the diabetic macular edema, as well as the proliferative diabetic retinopathy. Now we have several medications, one of which is brand new, faricimab, at the bottom there. These are medications that are used for multiple different diseases. And so there are different concentrations and different medications we use in different circumstances. There's a different strength as well as side effect profile for all these medications. So there's no one medication that's the best medication. I tend to start with Avastin, or bevacizumab is the generic term. And bevacizumab or Avastin is a medication that is actually not even FDA approved for use in the eye because it was invented for colon cancer and breast cancer. But it works by stopping blood vessels to tumors. In this specific case, it stops blood vessels in the retina where you don't want new blood vessels. These other medications were created by sometimes the same drug company that makes Avastin for use in the eye, and they all have their different places. And so we will use them in different circumstances. We also inject steroids in and around the eye. These different steroids we use sometimes can last for different lengths of time, but they also have different side effects. And side effects are an important thing to talk about when we talk about any medication. So when we're choosing a medication, we have to weigh the risks and benefits of the medication. And some of them, the benefits are pretty significant. Like the fluocinolone acetonide implant can last 2 to 3 years from a single injection. However, it is something that's going to be in your eye forever unless it gets removed with surgery because it doesn't dissolve. And it can also cause really high eye pressures, causing glaucoma, or it can get to the front of the eye and damage the cornea, and then you might need a corneal transplant. So there's a trade-off there. And so we will use different medications in different circumstances, depending on the level of disease we're trying to treat. And as I mentioned before, the subtenons injection, which is underneath the eye, and now there's a new way of injecting in the suprachoroidal space, which is actually in the outer coat of the eye, underneath the retina, through the wall of the eye. It's a new technique, and that can also be done. It's not currently approved for diabetes, but it's approved for inflammation. My guess is they'll probably get approval for diabetes at some point. So this is a patient who had proliferative diabetic retinopathy, a type 1 diabetic, and type 1 diabetes can be very bad. As you can see from the arrows here, those are really lacy, fine blood vessels that are new blood vessels. And these new blood vessels you see have bled into the eye. You can see the blood, which are the black and reddish kind of lines in the bottom there. I gotta annotate again real quick here. All right. And these are blood. This is blood in the vitreous here, called vitreous hemorrhage. And these are the blood vessels we're talking about. These lines over here are actually the eyelashes of the upper eyelid, because the way the camera takes pictures, it has such a wide angle, you can catch the eyelashes in the photo as well. But this patient was scheduled for a laser, waiting for authorization from the insurance company, and they missed their appointment. And suddenly that little blood vessel started bleeding a lot more. And when they bleed, what ends up happening is the eye is completely full of blood, and now the patient can't see anything. So this is a situation you don't want to get to, because when the bleeding is this bad, you can't apply laser treatment to the peripheral retina and prevent more bleeding in the future. So when someone's in this situation, they need either an injection of medication or more often than not, they actually need surgery to improve their vision. Clear that. So this is an ultrasound of the same patient's eye. You can see this white stuff here in the back. This is the ultrasound showing the blood. If it was a movie, you'd be able to see this swirling around in the eye. And this is what a vitreous hemorrhage looks like. We look at this because sometimes we can't see through the blood. So we want to see to make sure the retina underneath it is attached. So this is another patient who actually had relatively decent vision, 20/60. You can see the fovea in the top right picture here. This is showing a little bit of an abnormal macula. There's a little bit of epiretinal membrane on the surface of the retina there, which is why the vision is 20/60, not 20/20. And if you look at the bottom left, you see the fluorescein angiogram. You see all these new blood vessels where the arrows are showing that are all lighting up. They're very bright here because they're leaking. And this is a bad sign. When they have this much neovascularization, these blood vessels are about to do something very bad. So what we do typically in situations like this is we'll do a laser treatment in the peripheral retina. You see on the angiogram how it's very dark outside that bright area. That's because all the capillaries in that area have died. And when the capillaries have died, that retina is dead as well, and it's not seeing. So what we need to do is before those areas of the retina completely die, they release a lot of this factor called VEGF. And so what we end up doing is we end up applying laser treatment to it to kill off the dying retina, to sacrifice that, to prevent the release of this VEGF factor, to cause new blood vessels to grow and cause the blood vessels to bleed. But despite having laser treatment, this patient still got worse because these new blood vessels started scarring. And when they scarred, they started pulling on the retina. And you can see on this OCT scan on the right side here, it's actually stretching holes into the retina. And this dropped the vision from 20/60, which means what I can see at 60 feet, you have to be 20 feet away to see it, to counting fingers, which is so bad that you can't even read any letters in the chart. And this means that at 1 foot away, they can count how many fingers you're holding up, which is about the equivalent of 21,400. So that's pretty bad. That's about 3 times as bad as the big E on the chart. So this is much, much worse than legally blind. So when things get this bad, we're in a pretty bad situation. And the only solution to this is surgery. But thankfully, we have new treatments and we've gotten really good at surgery that now with good treatment, was able to bring this patient back to the 20/60 vision and remove all the scar tissue. This is the same patient. If you look back and forth at the photos, you can see the blood vessels with the same curvature are now nice and straight, and there's no scar tissue ripping the retina apart. All these spots you see around are laser scars that we did during the surgery to, again, prevent this from getting worse. And this patient did very well. And so thankfully, with these treatments, we're able to help people restore their vision. Technology is very wonderful. We're able to do a lot to help people in ways we weren't able to do it when I started my career. So I'm very thankful for that. But most importantly is we have better control of the blood sugar now. Like Dr. Yang mentioned, we have all these new drugs that do such a good job of controlling the blood sugars that compared to what I was seeing back, before 2010, before everybody had health insurance, it was a lot more difficult to treat these diabetic patients because we didn't have the medications we have now from the general diabetes side as well as the ophthalmology side. And with better medicines and tools and technology, that leads to better vision in our patients. Thank you. Let's take a look at the chat here. All right, if anyone has any questions, you feel free to enter them in the chat. And I'm happy to answer any questions. For myself or Dr. Yang as well, either questions are welcome.
Dr. Mehta, are you happy for them to ask you verbally instead of in the chat?
Yeah, verbally is great too.
Okay, great. Thank you. You can go ahead and unmute yourself if you have questions for either Dr. Mehta or Dr. Yang.
Okay, there's a question in the chat. What causes ERM and what's the difference between lattice and cobblestone? So those are 2 different questions. ERM stands for epiretinal membrane. There are several causes of epiretinal membranes. In diabetes specifically, the ERMs tend to come from the neovascular membranes that grow. And then after the blood vessels die, they tend to leave the scar tissue behind. And that causes an epiretinal membrane. Normally, epiretinal membranes are due to some sort of inflammation. Sometimes people have an autoimmune disease. Sometimes they just have lived a life. And during that life, your body develops inflammation, and that inflammation can grow scar tissue on the surface of the retina that can contract and distort the vision. That can happen to people who don't have any medical problems at all. And we do see it in people over the years. We tend not to see it in young people unless they have an autoimmune disease. Lattice and cobblestone are very different. So lattice degeneration is due to the eye growing long, which is typically seen in people who have high myopia, like I do. If you look at my glasses, you can see my face through the edges of my glasses because the curvature of these lenses so much. And my eyes are very long as a result of that. And so I have lattice degeneration. And lattice degeneration comes when the eye stretches and there's basically stretch holes in the retina. That's what lattice degeneration. Cobblestone is just the appearance of peripheral scarring in the retina that tends to happen over the years in some people that is not due to the stretching from lattice degeneration. Foods or supplements we have to eat for eye care. So people who have age-related macular degeneration, specifically dry AMD, if they have a form of it called intermediate dry AMD, there are vitamins that have been shown to reduce the progression to more advanced forms, but it has not been proven in people who have early AMD or a family history of AMD, only the people who have intermediate or worse AMD. These new treatments are nothing short of amazing. What do you envision as the future of diabetic retinopathy treatments? I believe eventually people like Dr. Yang will cure diabetes. And I think islet cell transplants are a pretty good start, you know? And so the problem is nowadays, the big problem with diabetes we're having is insulin resistance. Dr. Yang can talk some more about that. My wife is an endocrinologist as well. And she's always harping on me about causing my insulin resistance by having all the dessert I just had before this talk about diabetes. But you know, this is another thing, and I believe that there will be a cure for diabetes. The question is when that's going to happen. When I was in medical school, like 20 years ago, they said within 5 years, we'll have a cure for diabetes. Then 5 years later, they said within 5 years, we'll have a cure for diabetes. Then 5 years later, they said within 5 years, we'll have a cure for diabetes. So that's the problem. These things are a lot harder than we think they're going to be. But I believe that we will eventually be able to cure the underlying disease. Dr. Yang, do you have any comments on that?
Yeah, so I mean, diabetes is becoming a chronic disease like high blood pressure. I mean, for type 2, I'm specifically saying. Type 1 is a bit different story. Type 2 is like a high blood pressure. We don't say we cure high blood pressure, right? We don't cure hypertension. So I think type 1, we still have work to do, try to find a cure. For type 2 diabetes, we can just treat it. You live with a normal life. If you control your sugars well, we don't bother Dr. Mehta for the retinopathy. You have a normal life. Basically, that's the way it is. Type 1, we still have a lot of work to do. I agree.
Any other questions? Feel free to type or even talk. I like hearing the sound of your voice too.
If there are no other questions, we will thank Dr. Yang and Dr. Mehta for a great lecture tonight. We're recording it, so we will make it available and send it to those who've registered in the coming weeks. We have another lecture coming up on November 8th about the optical shop, annual eye exams, and new lens technologies. So if you're interested in attending that, please feel free to register. And thank you very much for attending. Thank you, Dr. Yang, Dr. Mehta.
Thank you, everybody.